Hello and welcome to Falcon Physician Review's Cardiovascular Physiology Online. My name is Mike Broman. In the first section, we'll be going over cardiac anatomy and cardiac pressures. Welcome to Falcon Physician Review's Cardiovascular Physiology section. My name is Mike Broman. I'm a cardiology fellow from the University of Chicago. Today we'll be going over different sections in this lecture. The first section is entitled Cardiac Anatomy and Pressures. The second section is entitled Cardiac Cycle and Heart Sounds. Then we'll go over cardiac mechanics, hemodynamics in the vascular system, then control of the cardiovascular system, and then cardiac electrophysiology and electrocardiography. In the first section, entitled Cardiac Anatomy and Pressures, we will go over the different chambers in the heart, the normal pressures in the heart, and the blood vessels. The cardiovascular system itself is composed of the heart, as well as the circulatory system, including arteries, veins, capillaries, as well as lymphatic vessels. The cardiovascular system works to deliver oxygen and nutrients to these target organs, as well as removing its waste products. The anatomy of the cardiovascular system is very important for the test. You should be able to memorize the different cardiac chambers, which valves separate them. You should remember the pressures in the different chambers. You should know about the pulmonary circulation, and you should know about the special peripheral circulations, all of which we will go over today. The four cardiac chambers you should know, the two atria and the two ventricles, are separated by valves. The right and left atria are generally thin-walled and have low pressure. The right and left ventricles are thick-walled and have higher pressure. As you know, deoxygenated blood enters the right atrium from the superior vena cava and the inferior vena cava. Also remember that deoxygenated blood can also enter the heart through the coronary sinus, which drains the coronary arteries. The coronary sinus drains into the right atrium. There are also very small cardiac veins which can drain directly into the cardiac chambers. The left ventricle is the usual target for these small veins. Deoxygenated blood from all of these sources flows across the tricuspid valve into the right ventricle, and then up into the pulmonary artery, and across the pulmonic valve into the pulmonary circulation. Oxygenated blood returns to the left atrium from the lung. It then flows across the mitral valve into the left ventricle, and is then ejected across the aortic valve into the systemic circulation. Here's a diagram of the cardiac chambers you should know. Something you should remember is that the average person has 4 pulmonary veins, 2 from the left and 2 from the right. You should also remember that the coronary arteries, which are not pictured here, actually leave the aorta above the level of the aortic valve. This will become important as we will discuss later. Here is a normal chest X-ray. Some things that you may see on the USMLE that you may want to remember are that the borders of the heart are readily apparent on a normal cardiac X-ray. The right atrium, as you can see here, bulges out to the left side of your screen on the right side of the patient. The left ventricle size can be assessed by looking at the left cardiac border. You can also see the aortic knob in a superior direction from the heart. All of these can become enlarged or calcified. These are things that you should be able to recognize on the test. Looking at the heart here in cross-section, you can see that the pulmonic valve is the most anterior valve in the heart. Just posterior to the pulmonic valve is the aortic valve. And posterior to the aortic valve are the mitral valve to the left and the tricuspid valve to the right. The mitral valve is the only valve out of all 4 which normally has 2 cusps. All of the rest of the valves have 3 cusps. The aortic valve, when it does have 2 cusps, is called the bicuspid aortic valve and is commonly associated with the disease states such as aortic insufficiency and aortic stenosis. The 4 cardiac valves serve to produce unidirectional blood flow through the heart. Cardiac valves are passive structures, meaning they do not flex on their own. They require blood movement through the valve to open and close. They're composed of fibrous tissue that is covered by an endothelial layer. These valves offer very little resistance to flow when they are open. Obviously, when they are closed, they do not allow blood to flow. A normal pressure gradient across an open cardiac valve is approximately 1 to 3 millimeters of mercury. When valves have a higher pressure gradient across them, this is what we call a stenotic valve. Valves are supported by chordae tendineae, which are small fibrils of fibrous tissue that prevent the bulging back or prolapse of the valve. We will discuss heart valves more in the heart sounds section. In this simplified diagram, you can see the ascending aorta moving up from the heart. Denoted is the location of the aortic valve, and you can see the right coronary artery going to your left and the left main coronary artery going to your right. These coronary arteries arise from the aortic valve coronary cusps. The left main coronary artery supplies the left anterior descending and the left circumflex artery normally. Sometimes a smaller branch called a ramus branch may arise between these two arteries, between the left circumflex and the left anterior descending. The ramus intermedius is only uncommonly seen in most people. What's important to remember is that these arteries take off from the aorta superior to the level of the aortic valve. The right coronary artery normally supplies the right atrium, the majority of the right ventricle, and a variable portion of the left ventricle. In general, the inferior wall of the left ventricle is supplied by the right coronary artery. In most people, the right coronary artery gives rise to the PDA, or the posterior descending artery. This artery courses vertically along the underside of the heart. It supplies the posterior interventricular septum and the inferior wall. In people that have a PDA supplied by the RCA, we call them right dominant. In the remaining 15% of people that do not have a right dominant circulation, the PDA is a branch of the left circumflex coronary artery. These people are said to have a left dominant circulation. The left main coronary artery normally supplies the left atrium, most of the interventricular septum, and the left ventricle. As you can see, the left coronary artery supplies much more of the heart myocardium than the right coronary artery does. The left main coronary artery bifurcates into the LAD and the LCX. The LAD, or the left anterior descending artery, supplies most of the interventricular septum and the anterior wall of the left ventricle. The left circumflex supplies the lateral wall of the left ventricle. The arterial supply to the sinoatrial node usually is derived from the right coronary artery. This occurs in 60% of people. In 40% of people, the arterial supply to the SA node is supplied from the circumflex artery. It's important to remember that during left ventricular systole or contraction, the pressure inside the muscle of the heart approaches that of the aortic blood pressure. This causes an occlusion of the parts of the coronary arteries that are inside the muscle, the intramyocardial portions. Therefore, in the left ventricle, coronary perfusion pressure is usually determined by the difference between the aortic pressure and the left ventricle muscle pressure. This is why in the left ventricle, diastole is the most important period of time for perfusion of the muscle. During systole, the pressure is simply too high in the muscle for the blood to enter. This is why we consider mean arterial pressure more accurate when we are trying to figure left ventricular perfusion pressure. Mean arterial pressure depends heavily on diastolic pressure, more than it does systolic pressure. This diagram on the top shows aortic pressure. The minimum pressure at the first dotted line is the diastolic pressure. You can see it's approximately 80 millimeters of mercury. Systole is the period of time between the two dotted lines. And you can see that aortic pressure rises appropriately during systole. The maximum pressure is the systolic pressure. In the second diagram, you see coronary blood flow in millimeters per minute. You can see the left coronary artery has a much higher blood flow during diastole, after the second dotted line, because during diastole, the muscle relaxes, allowing blood to enter. The right coronary artery, however, has a much thinner volume of distribution, meaning that the muscle to the right ventricle is much more thin and does not depend on diastole for its filling. The right ventricle does not generate as high a pressure to counteract the coronary blood flow. Coronary perfusion decreases as aortic pressure decreases. Similarly, as the aortic pressure rises, coronary perfusion pressure goes up. Coronary perfusion also will decrease as an increase in ventricular end diastolic pressure occurs. End diastolic pressure of the ventricle is also known as preload and involves stretching of the myocardium. As the heart rate increases, this also will decrease coronary perfusion because the faster the heart beats, the less time there is for diastole. And as you know, diastole is responsible for most of the coronary perfusion of the heart. This graph shows as heart rate increases on the x-axis, the percentage of the cardiac cycle that is in diastole decreases. This shows that as a person's heart rate goes up, coronary perfusion in general goes down. So how does the body counteract this? Normally, changes in myocardial blood flow are entirely due to variations in arterial tone in response to metabolic demand, meaning as the heart muscle works harder, it releases adenosine and other molecules, but adenosine is the major one that you should know. Adenosine, which is a breakdown product of ATP, causes coronary vasodilation. Coronary vasodilation increases the amount of perfusion to the cardiac muscle. There is some autonomic innervation to the coronary arteries. It's primarily sympathetic in nature and involves beta-2 receptors. As epinephrine is released into the system, it binds these beta-2 receptors and causes coronary vasodilation similar to that which happens in skeletal muscle. There is very little parasympathetic activity on the coronary arteries. It is also vasodilatory. The oxygen demand of the myocardium is usually the most important determinant of the blood flow to the heart. One important difference you should know about the myocardium is that it extracts much more of the oxygen from the arteries than other tissues. It extracts approximately 65% of the oxygen compared to other tissues which only usually extract about 25% of the oxygen. Therefore, the myocardium cannot really compensate for reductions in blood flow by extracting more oxygen because it's already extracting a great deal of oxygen from the blood. Therefore, the heart is able to increase its amount of oxygen only by causing coronary vasodilation, and this occurs mostly because of adenosine. The heart rate and the ventricular end diastolic pressure are important for supply and demand, as we mentioned before. In the pulmonary circulation, deoxygenated blood from the right ventricle crosses the pulmonic valve and goes into the pulmonary arteries, and then enters the lungs. You should remember that the bifurcation of the pulmonary artery goes under the arch of the aorta. There are usually two main pulmonary arteries, which give rise to smaller branches of the pulmonary arteries. These pulmonary arteries supply the alveolar capillaries. Alveolar capillaries at the bottom of the lung, or the inferior side of the lung, make up west zone 3. This portion of the lung is very heavily perfused. The alveolar capillaries at the top of the lung, if the patient's standing, would be in west zone 1 and would be less likely to be perfused. After the blood is oxygenated, it returns to the heart through the pulmonary veins. A normal patient has 4 pulmonary veins that all enter the left atrium. This tracing shows the pressure in the right atrium during the cardiac cycle. We start off in diastole, and the first bump you see in the pressure tracing is A. We call this the A wave. The A wave is followed by the X descent. During the X descent, most people have what we call a C wave. Then during systole, you'll see the pressure in the right atrium slowly rising to a V wave, followed by a Y descent during diastole. What do these waves mean? A wave results from right atrial contraction. This immediately follows a P wave on an EKG. If a patient is in atrial fibrillation, they will not have an A wave. The X descent represents blood leaving the right atrium. As blood leaves the right atrium, the pressure will drop. This also corresponds to right atrial relaxation. The C wave represents a positive deflection. This comes from the tricuspid valve closure, which occurs during the X descent. The V wave actually represents a passive filling of the right atrium. The nomenclature V wave is confusing. Many people believe that a V wave represents contraction of the right ventricle, which pushes the valve up into the right atrium, but this is not usually true. There is not usually a large contribution from the right ventricle to the V wave, except in patients that have tricuspid regurgitation. The V wave represents passive filling from venous return. The peak of the V wave represents the point where the tricuspid valve opens. The Y descent is the subsequent decrease in right atrial pressure when the tricuspid valve opens. When you see a patient who has heart failure or some other shortness of breath similar condition, you may want to check their jugular venous pulse. The jugular venous pulse is actually analogous to the right atrial pressure. There are no valves between the jugular vein and the right atrium. Therefore, we use jugular venous pulse as sort of a surrogate to the right atrial pressure. The amount of centimeters that you see a jugular venous pulse above the right atrium can be estimated to be the right atrial pressure. The number of centimeters, let's say it's 5 centimeters, can be equated directly to 5 millimeters of mercury. So how do you measure the jugular venous pulse? First of all, you position the patient, whether it's lying down or standing up, so that you can see the jugular venous pulse. Once you see the pulse, you find a point lateral to that pulse that is directly perpendicular up from the patient's angle of Louis, or the sternal angle. You measure the distance from that lateral point down to the angle of Louis, and then add about 4 or 5, depending on how tall the patient is. This is because the right atrium is usually 4 to 5 centimeters below the angle of Louis. Once you add 4 to the number of centimeters that the jugular venous pulse is above the angle, that will give you your approximate jugular venous pulse and will give you your approximate right atrial pressure. This is helpful for diagnosing right and left-sided heart failure. You should be able to see the A and the V wave on the venous pulse. If you only see one wave, then the patient may have atrial fibrillation, or it may be a carotid pulse and not be a venous pulse at all. The right ventricular pressure is here seen superimposed on the right atrial pressure. You can see that the right ventricular pressure goes up during systole. This occurs during tricuspid valve closure. At that point, the right ventricular and the right atrial pressure change from each other. At the end of systole, right ventricular pressure diminishes to the point where the tricuspid valve opens. At that point, the right atrial and the right ventricular pressures are approximately equal. A normal right ventricular pressure is 15 to 30 millimeters of mercury systolic over 1 to 8 millimeters of mercury diastolic. A normal right atrial pressure is normally 2 to 5 millimeters of mercury. Here you can see pulmonary arterial pressure superimposed on this diagram. At point C, the pulmonic valve opens. At that point, right ventricular blood enters the pulmonary artery. At point D, the pulmonic valve closes. A normal pressure in the pulmonary artery equals approximately 15 to 30 millimeters of mercury systolic over 4 to 12 millimeters of mercury diastolic. A mean pulmonary arterial pressure greater than 25 usually denotes pulmonary hypertension. Here you see a left atrial pressure tracing. This tracing is almost exactly identical to right atrial pressure tracings, but the pressure is higher. Usually, a left atrial pressure is between 6 to 12 millimeters of mercury. You can see the A wave, the V wave, as well as the X descent, Y descent, and the C wave. The difference with the left atrium is that it's very difficult for us to measure the left atrial pressure directly. What we usually use to measure the left atrial pressure is what's called the wedge pressure. The wedge pressure is measured using a Swan-Ganz catheter. This is a venous catheter that we insert into either the jugular vein or the femoral vein. And we use it to go into the heart, into the right atrium, the right ventricle, through the pulmonic valve into the pulmonary artery. And then if you look at the bottom of the slide, what we do is we wedge the catheter into the pulmonary artery. The tip of the catheter has a pressure sensor. When the catheter is wedged, the sensor on the tip actually measures pulmonary venous pressure, and pulmonary venous pressure is approximately equal to left atrial pressure. Therefore, we're able to measure left atrial pressure without actually entering the arterial system. And as you can imagine, the arterial system is more dangerous to enter because it's a higher pressure system. If a patient has a very high wedge pressure, we may think that they could be in left ventricular failure because blood is starting to collect in the left atrium when the left ventricle weakens. The left atrial pressure waves are analogous to the right atrial pressure waves. The A wave results from left atrial contraction. The X descent is caused by blood leaving the left atrium. The C wave is caused by mitral valve closure. The V wave is caused by passive filling of the left atrium from the pulmonary veins. And the Y descent is caused by the pressure drop in the left atrium when the mitral valve opens. Here are all the left-sided heart pressures superimposed on the same graph. They're very similar to the right-sided heart pressures, but the pressures themselves are elevated. The left atrial pressure on the bottom is 6 to 12 millimeters of mercury. The left ventricular pressure is 90 to 140 millimeters of mercury over 5 to 12 millimeters of mercury. And the aortic pressure is usually 90 to 140 millimeters of mercury over 60 to 80 millimeters of mercury. You can see points A, B, C, and D where the mitral and aortic valves open and close. You should memorize these points because they're very commonly seen on the test. Point D is the most commonly seen point on the test. This is the place where aortic valve closes. Between points D and B, there is no outflow or inflow from the left ventricle. We call this isovolumetric relaxation. From points A to C, both the mitral valve and the aortic valve are closed as well. We call this isovolumetric contraction. Here's a simple question. What causes an enlarged V wave on a right atrial tracing, and what causes an enlarged V wave on a left atrial tracing? As we discussed before, either tricuspid or mitral regurgitation can cause enlarged V waves on right atrial or left atrial tracing. Also, for a right atrial tracing, an atrial septal defect or constrictive pericarditis can cause an enlarged V wave. For a left atrial tracing, remember that it's often difficult to see V waves because you're not actually measuring the left atrium in most cases when you're measuring a wedge pressure. You're measuring the pulmonary veins. Therefore, sometimes it's difficult to make out the A waves and the V waves. This ends our section on cardiac anatomy and cardiac pressures. In the next section, we'll be going over the cardiac cycle.